Thank you very much for joining us today for the University of Illinois Chicago School of Public Health Global Health Programs Kickoff event. So this kicks off our monthly Global Health Speaker Series lecture. And we are very excited today to host Professor Len Rubenstein from Johns Hopkins Bloomberg School of Public Health. I had the pleasure of meeting Professor Rubenstein at a conference put on by Med Global in Chicago last year. And if you don't know Med Global, they are a humanitarian organization that provides emergency response and health programs to victims of wars and disasters and to marginalized communities around the globe. They actually have a conference coming up. I figure I might as well mention it because this audience might be interested in it. November 4th and 5th here in Chicago. So check out their website, Med Global. So without further ado, let me get started here. Professor Len Rubenstein is a professor of the practice in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health and interim director of its Center for Public Health and Human Rights. He is also a core faculty member at Berman Institute of Bioethics and the Center for Humanitarian Health at Johns Hopkins University. Prior to coming to Hopkins, Professor Rubenstein was a senior fellow at the United States Institute of Peace, and before that, president of Physicians for Human Rights. He has been the recipient of numerous awards, including the American Public Health Association Sidel Levy Award for Peace. He is a graduate of Wesleyan University and Harvard Law School. He founded and chairs the Safeguarding Health and Conflict Coalition and is the author of Perilous Medicine, The Struggle to Protect Healthcare from the Violence of War, published by Columbia University Press in 2021. And it's a wonderful book. I did just take a peek on Amazon and see that there are only 12 books left. So get your copy soon. I'm sure that more will be coming though. So without further ado, we're going to get started. Please feel free to submit any questions that you have in the chat, and Professor Rubenstein will give his lecture, and then we'll address the questions upon the conclusion of his lecture. So thank you very much, everybody, and Professor Rubenstein, the floor is yours.
Thank you, Allison, and I'll share my screen. It's a privilege to be with you today, and it's especially a privilege because despite the horrors of violence against healthcare, it is still a marginal subject in medicine and public health and nursing, including in academic settings. So it is long neglected within the global health community, both at the institutional level and at the practical level, and there was very little attention by the international community. So it's a terrific opportunity for me to talk to you about this. What you see on the screen is a painting of the Battle of Solferino in 1859. And if you look carefully at the painting, you can see there are a number of wounded soldiers on the field. And at the time, those who were trying to attend to these soldiers were considered at the same as enemy soldiers and could be attacked and shot. And as it happened, when that battle took place, a man named Henri Dunant, a Swiss businessman who was looking for Napoleon III, who was the head of France and was there for the battle, he wanted to meet with him, which is a rather crazy thing to do, but he saw the battle and he wrote a book revealing how appalled he was at the horrors of war, but also the lack of any attention to the wounded on the field. And he came up with an idea that we have to prevent, or if we can't prevent, at least alleviate the horrors of war. And his idea was based on what we call the principle of humanity, that when there's human suffering, we recognize that there's a moral sense of the importance of all human life. And that led in 1864 to what was the first Geneva Convention. Not only was the first Geneva Convention, it was the first international treaty that had anything to do with human rights. And not only that, we think of the Geneva Conventions as about the laws of war in general, but the exclusive focus in 1864 was on the protection of healthcare in war. And I have on this slide what could be a whole course, 3 ideas from the conventions, not just from 1864, but from all the iterations and developments in the 150 years since. The 3 basic ideas is that combatants, the armies, whatever the armies may be, whether armed groups or state militaries, have an obligation to care for the wounded and sick and not attack hospitals, ambulances, health workers, or civilian infrastructure. The second idea, much more recent within the last 50 years, is that combatants not only have to not attack, they have to take precautions whenever they engage in a military attack. They have to distinguish between military and civilian objects. That's the principle of distinction. And they have to abide by the principle of proportionality, which is designed to prevent excessive collateral damage. We often think that civilian harm in war, if it's collateral damage, it's okay, but it's not okay. It has to be proportional to the military objective sought. And the third principle has to do with a recognition of the ethical obligations health workers have in conflict, and that is to treat people and to treat them impartially without distinction based on who they are or which side they're on or even what acts they've committed. And the conventions say you can't punish health workers for adherence to their ethical duties. The problem is that this has long been ignored. These rules have been ignored almost from the start. And just as a personal note, when I was at Physicians for Human Rights in the 1990s and the early 2000s, we did a lot of work in reporting on attacks on healthcare and war. The top picture is from Kosovo, where hundreds of health clinics were burned. Second picture is from the capital of Chechnya, Grozny, where the Russians regularly bombed hospitals. And the last is from the Israeli-Palestinian conflict, where during the Second Intifada in the early 2000s, ambulances were attacked even by tanks, as you see, and their passage was blocked when people needed to be reached. And we issued a lot of reports, but nothing ever happened. It never got on anyone's agenda. And for that matter, there was almost no research on this question. And in 2010, I wrote an article for The Lancet saying, I have a quote from my article saying, this is happening, but no one pays attention and no one is held to account. By a lot of circumstances, at this time, there was a lot of ferment about this issue. And when the Syria war began, even more attention, and the International Red Cross Committee of the Red Cross got involved, and the Safeguarding Health in Conflict Coalition that Allison mentioned got started. And we said, we have to do something about this. And that's what I want to talk about. What the scope of the problem is, what the law, how the law has applied or not applied, discuss why healthcare is attacked, what its impacts are, and what we can do toward mitigation of the impact of the attacks, preventing the attacks, and accountability for them. So that's my topic for today. Let's talk about the problem. This is a map of attacks on healthcare. I know you're not going to be able to see all the dots or the numbers, but just to give you a sense, there were in 2022 more than 2,000 attacks on healthcare across the world. And Other studies we've done through the Safeguarding Health and Conflict Coalition have shown that a health worker is killed in a war every 3 days somewhere in the world. And a hospital is attacked every other day somewhere in the world. And of course, these are places where the health system is most fragile because of the war and the population is in greatest need. Now, I show you a map, but I think we have to see the reality. This picture you may have seen before. This is from a Russian attack on a hospital in Mariupol, Ukraine, and the woman on the stretcher on the incongruous polka dot blanket was there in the hospital to give birth. And this is what happened. And what happened soon after this picture was taken is that she died. That's the reality of what happens in these attacks. And here again, going back to scale, we recently passed a milestone in Ukraine where there have been more than 1,000 attacks by Russia against healthcare institutions, health workers, ambulances, and you can see the distribution based on data collected by the NGO Insecurity Insight. We know about Ukraine, of course, but there are so many places that we don't know much about. And it may surprise you that in Myanmar, since the coup in 2021, there have also been 1,000 attacks. And you can see some of the numbers about injuries and deaths and facilities damaged. What is dominating Myanmar, these thousands, however, is arrests of health workers. And we'll see that in the slide to come. But I want to show you a little chart of trends. It's a little misleading at first to see the rapid rise, because in the early years of trying to document and collect data on these attacks, no one had ever done it before, and it's very complicated and difficult to do so. So before about 2020, we always had a disclaimer in our reports that the report was likely a large underestimation because so many attacks are not reported. It's still the case that many are not reported. But by about 2020, we concluded that we probably picked up most of them. And there, between 20 and 22, you see this dramatic increase of number of health workers affected, and that corresponds to the number of attacks. And you can see killed, kidnapped, injured, arrested. So in the last few years, despite the attention the issue has gotten in the last decade, the problem is getting worse. And here's what I alluded to earlier in Myanmar. You can see that close to 800 health workers have been arrested there. Nobody really knows about this. It's all having to do with the fact that they're opposed to the regime, or they're providing care for people opposed to the junta that is now governing Myanmar. There's something else about this graph, however, that because Myanmar has so many, you lose sight of the numbers in other places, which are still significant. Iran in particular, Afghanistan, 233 arrested, Syria, 42 arrested, even when we're used to thinking that the Syria war is winding down. So we have to ask, why is healthcare attacked? And I looked at this issue when I decided to write my book. And I wanted to look at not the motives. We know motives vary. They're easily accessible in many cases. Ethnic hatred, dehumanization of enemies. I wanted to get at what I call the logics of the violence. Like, what is the reason, the military reason, the political reason that they would want to attack healthcare? And they're not the same. These reasons may not be the same as the reasons they attack civilians generally. And I came up with the 5 you can see on the screen, and I'll go through them quickly one by one. One is the strategy of war, and that's the most familiar. That was very clear in Syria. An independent international commission on the war in Syria, appointed by the UN, concluded back in 2013, and it's been confirmed in many ways since, that it was designed to get a strategic advantage by depriving armed groups and their perceived supporters, that is, the entire population, of medical care. It forced people to move. It was designed to demoralize their opponents, and the strategy has continued even today. A second is tactical advantage. That is, there's no strategic reason, but in the fighting in a particular place, it makes tactical sense to attack a hospital. And here is a hospital in Raqqa, Syria, which the US and its allies was trying to capture. It ended up destroying the city, actually, and take it away from ISIS. And you could see that this hospital had this big turret type thing on top, and it was being used by ISIS to fire into the city. On the other hand, that building, the hospital itself, still had patients in it. And one of the precautions that I mentioned before is to make sure that the force used in a military operation is designed to prevent harm to civilians. And that could be done in a lot of different ways, but you just can't fire at a hospital because it's being used for military purposes without trying to restrict harm to civilians. The US forces and our allies ignored that rule because it was advantageous and destroyed the hospital. Another very common problem is what I call recklessness or inconvenience. And this was most prominent in the war in Yemen, where the Saudis had modern air power. They had the capacity to accurately target. There were 30,000 places in Yemen which were identified on lists shared with the Saudi military that were protected sites. And they had a sophisticated military. In fact, they had training from the British and US military on how to target, and they kept hitting hospitals anyway. And the reason was they didn't really take the time, the effort to make sure they didn't hit civilian structures. And many, many hospitals were hit as a result, many civilians killed. On the right, you see a Palestinian ambulance. In the Gaza wars, we saw that the International Committee of the Red Cross had an arrangement with both sides to clear ambulances for passage to make sure they weren't carrying weapons of any kind. And what happened was, even when they were cleared, the Israeli military attacked them because it was mostly inconvenient to follow the procedures, train the soldiers, hold soldiers to account if they violated the rules. Another very common reason is that warring parties object to treatment of enemies. This is an infamous, as it were, picture of a Chechen surgeon named Hassan Bayev amputating the leg of a Chechen rebel soldier and leader whose leg had been mangled by a landmine. And for having treated this man, Russians targeted him. Dr. Bayev was also targeted by the Chechens for treating Russians in accordance with its own duty of impartiality of care. And this happens all over the world, and that's one of the factors that's at play in Myanmar, where all those arrests take place, that the parties think you shouldn't treat enemies. The fifth, what happened to my fifth? I don't have a slide on the fifth. The fifth was common in the DRC during the Ebola crisis, where community groups felt so neglected by the government, their needs were so unmet, and it showed contempt for their needs, that they were very angry. And when the Ebola restrictions came in, the draconian rules about transmission, understandably, for preventing transmission of Ebola, they reacted with violence. They were mostly community groups who were just expressing hostility to the government. Now, what are the impacts? There are a lot of ways of looking at this. This nice graphic, which came from an article about a cholera outbreak in northwest Syria, brings together the factors that contributed to the outbreak. And many of them are either directly or indirectly a result of attacks or obstruction of healthcare, from inadequate access of humanitarian supplies to attacks on health infrastructure, including sanitation, the lack of facilities and health staff who have left because of the violence inflicted on healthcare. And this study was performed with respect to other kinds of health issues, from reproductive health to other infectious diseases. And you can see how these are both discrete and they're reinforcing effects of violence, because one aspect of violence affects another cause of the outbreak. And we can see results like this not only in Syria, but in Yemen. It looks on this chart like that red line is the top of the graph, but it's not. It's a level of prevalence or incidence of cholera. And you see it's literally off the charts. Why did this happen? Because part of the Saudi bombing that I mentioned a moment ago was against water infrastructure, and this was the result. There are other results on health workers. A lot of you are or will be health workers who are so dramatically affected, and the trauma of experiences these attacks, especially over time, are extraordinary. That depression, anxiety, the sense that my mind will explode is pervasive. And people love to talk about the resilience of the health professions in war, but that really overlooks the suffering and the trauma they experience. And we've seen this recently in Sudan, where one medic said, when shelling got worse, we started to discuss what would be the most painless part of the body to be shot in, and began to pray instead to die painlessly. That's Sudan today. Now, as part of the attention to this issue, there has been more research, not just in terms of qualitative studies on the reactions and based on interviews of health workers, but some surveys. And these two surveys were in South Sudan on the top, and Nigeria on the bottom, where a very high percentage of health workers surveyed reported major distress, inability to work, and a huge impact on populations. There's another dimension to impacts that wasn't well understood until recently. In fact, COVID is what highlighted the problem of moral distress, or really more properly, moral harm to people working in healthcare. And that is that you feel like you're not doing your job because of circumstances beyond your control, but feel guilty for it, that you're trained to do something to help people and you can't. And we've seen this over and over again. These two quotes are from Syria, the idea that it was the most painful moment to feel that you let people die because you can't serve everyone. And what they do, they flagellate themselves. I am subjected to constant punishment and self-lashing continuously without interruption. This is what doctors have told us. So those are the impacts. What do we do about this? We've made a lot of progress on mitigating the impacts of attacks. These are some of them. Using telemedicine. In Syria, they put hospitals underground. Task shifting when more skilled health providers leave and lower trained health workers take over. There are training innovations from how to do surgery in war to what you do in a case of a chemical attack. Mental health interventions for the population, although there's been very little on mental health interventions for the healthcare providers. Salary supports for people working in the field, advanced security procedures, and new governing structures to coordinate care better, particularly to take into account when hospitals or healthcare institutions are destroyed in one place and you need to make decisions about where healthcare can be made available. So in mitigation, we've made a lot of progress, but that's not going to stop anything. That's after the fact. So how do you prevent these attacks from occurring? And here again, I tried to figure out what was needed. And what I conclude that at the beginning, at the most, you need a leadership commitment from people in power, military leaders, political leaders, to follow the norms that we began this talk with in military operations. That is, follow the Geneva Conventions. And whether there's an armed group or a state military, you need that leadership. The other two sources are pressures, incentives for accountability. Accountability both for perpetrators and accountability for adherence to the norms and the accountability of the leadership in complying with those norms. So these happen or are available on both a domestic and international level. In 2016, there seemed to be a breakthrough. For the first time in history, the UN Security Council passed a resolution on the protection of healthcare in war. And it was a very thoroughgoing resolution requiring governments to reform their laws, to reform their military operational procedures in the field, to have better accountability procedures, and to hold perpetrators to account. And at the international level, to fill the gap if domestic reform failed or compliance failed, including prosecutions in international courts. Unfortunately, however, that resolution, now 7 years old, has been largely ignored. And what we see instead, at the UN, there's been a lot of deference to perpetrators in aid manipulation, which has been prominent in Syria, in humanitarian access. We've seen that not only in Syria, but in Ethiopia, where access is blocked for military or political reasons, and for political pressure on UN agencies not to call out perpetrators as they're supposed to do. Meanwhile, we have paralysis at the Security Council in referring cases to the International Criminal Court because of the veto of permanent members. And we have a lack of leadership at the organization that should be the world leader on this, which is the World Health Organization. It was required to establish a tracking system for attacks on healthcare, and it did, but it's so flawed that we don't even know where these attacks are happening beyond the country level or exactly what happened. At the same time, governments have not implemented the 2286 resolution, and there's continued impunity. There's never been a major prosecution of a of a perpetrator of an attack on healthcare since the modern era of international prosecutions began in the 1990s. There have been many people prosecuted both in International Criminal Court and hybrid institutions, but there's still not a case against perpetrators of violence against healthcare. And another example, a simple level, is there's an institution in the UN on children in armed conflict, a special agency to track attacks on children in armed conflict. And one of the attacks they monitor is attacks on healthcare. And they're supposed to list in an appendix to the annual report persistent perpetrators. And that's the blacklist referred to in the headline you see. And what happened was the Saudi government threatened humanitarian aid cutoffs to the UN if it wasn't removed. And they were removed. And the second article from The Lancet is about the surveillance system that I mentioned, which reported 0 attacks in Ethiopia, even though the attacks became known worldwide in the media and elsewhere. So what do we do in the face of this? I have five ideas to share with you. One is we have to follow through on reforms of military practice and law. This is not that hard. And we're talking not only about the rogue states, we're talking about advanced militaries with values that reflect the Geneva Conventions, including the United States, but have not done anything to change military practice and law. In fact, it's still a crime in this country to provide health care to an alleged terrorist, which is completely contrary to the values of the Geneva Convention. A second is to restrict arms sales to perpetrators. I mentioned the recklessness of the Saudis, but they were using US weapons in making these attacks. And we never stopped those sales to the Saudis. A third dimension is to impose real consequences. And those consequences can be anything from diplomatic initiatives. It could be sanctions. It could be withdrawing ambassadors. It could be all kinds of trade restrictions and simply démarches and other messages designed to pressure another country. And of course, there have to be legal consequences sometimes, and that includes prosecution. There needs to be global leadership at WHO, as I've mentioned, and governments, and we have to reform the Security Council so that no state can veto a referral to the International Criminal Court. Finally, there's one thing not on my list, but it's so important for all of us in global health, and that's solidarity. Here on the top, you see a march in Sudan of doctors protesting repression. In the bottom, you see doctors in Myanmar who were among the leaders of the civil disobedience movement against the coup. They need our support. And a lot of times, solidarity is not the same as going there and stopping the violence, but showing our colleagues that we care about them, we recognize what we're going through. And I can tell you from personal experience that that matters. The idea that someone cares about what's happening to them means is huge for people who are in the midst of it. The alternative is abandonment. And this quote is also from Syria that said, "Death has become normal to the rest of the world. No one is reacting. People need support as well as intervention." And I think it's on us to make sure that this happened. So that's the end, and I will stop sharing and happy to answer any questions.
Thank you very much for that talk. I think it's a lot for everybody to take in. It's a bit overwhelming indeed. I just want to encourage the audience members to please submit any questions that you might have into the chat. Professor Rubenstein, I really appreciated that you laid out the logics, the logics of violence in terms of the tactical advantage, the military reasons, political reasons, and then you kind of put forth some opportunities that the global health community can engage in to demand accountability and stuff in terms of reforms of military practice and law, restricts arms sales to perpetrators. You know, we're in academia here, we're in an academic environment, and I'm wondering if you could comment on things that maybe we can do from both the administrative perspective or people that build curriculum into these public health and medical education programs, as well as for students that might be interested in getting involved in humanitarian health programming.
Well, thanks for that question. I didn't really cover that in my talk, so I'm glad to talk about it. One thing that's so important is the traditional academic roles of research and teaching. There has been very little research that's been published in peer-reviewed journals on this. In fact, a colleague and I did a review going back to the 1980s of studies of violence against healthcare, and there was an average of one article a year. Given the consequences of these attacks and on population health, that's pretty astonishing. In the last 5 years or so, the number of articles and papers published has increased, but there's still very few, a few dozen probably. So there's work to be done, and there are methodological issues in how you determine the effects of an attack on healthcare as opposed to the general effects of the war itself. So there's plenty of room for research. Second, this topic is still not covered in most schools of public health, much less schools of medicine. There are humanitarian programs in some medical and public health institutions, but they tend to focus on services and designing and evaluating programs or how to be a good humanitarian worker. The problem that we're talking about today is almost totally neglected. So we need to have curricular reform, and that's one thing students can demand. They can say, why is it that you're not offering courses on an issue that has such an enormous impact on the health of millions of people? And I mean millions, tens of millions of people. And we're not covering it. We're not understanding it. We're not getting educated about what can be done. The third thing to do is to get involved. There was a breakthrough after the war in Ukraine broke out. For the first time, the Association of Schools and Programs in Public Health issued a statement condemning Russia's aggression in Ukraine, which was extraordinary because most times public health does not want to get involved in these kinds of issues of war and peace. There's a lot of room for advocacy. And so there are a lot of opportunities to get involved. And I think for you students, when you have to do capstones or papers or whatever kind of project you're required to do, or to take an elective somewhere else, consider doing some work in this area. There's a huge need, and because the need is so great, it's usually not hard to find people who would like your help. So I think there's a lot that could be done.
Good. Again, just encouraging people from the audience to please submit any questions into the chat. Professor Rubenstein, I understand through our conversations that you have an upcoming trip to Ukraine. And I'm wondering if you could just briefly talk about it in the sense that it kind of gives an example of practical steps that people might be going through or might go through when they're trying to make a difference in this field.
Well, first I will talk a little bit about what's happened in Ukraine. I mentioned there were 1,000 attacks. It wasn't just attacks on hospitals, but if you recall, last winter, there were consistent attacks on the health infrastructure and the electrical grid, particularly. And what's been remarkable about Ukraine is, I said I don't like the word resilience, but the health community, from the Ministry of Health to local health providers, have, against all these struggles, kept health system functioning there. Weakened, to be sure, very weakened. And there are many crises there. There's a huge population mental health crisis, which is basically unaddressed. There's still problems of access to drugs. There are problems of population access to services because they risk travel. But people there are truly heroic. And one of the reasons to go there is an expression of solidarity and support, and to try to help them get the word out to the world how the health system needs to be supported. So I expect to learn a lot there, but it's also to try to show support in the way we can. And there are other ways of supporting people in Ukraine and many other countries.
Great, thank you. We do have a question from the audience. Let's see. Okay. How does Dr. Rubenstein think that the mindset of world leaders regarding the protection of health facilities and health workers in war can be adapted to work towards better enforcement?
Boy, that is it's both a terrific and very hard question. Almost every country, I think maybe every country in the world, has signed on to the Geneva Conventions. It's the most ratified human rights related treaty in the world. And yet, we see that non-compliance is almost the norm. Not only non-compliance, but contempt. I mean, if you see what Russia's doing in Ukraine and what Syria and the Russians did in Syria, and what the junta is doing in Myanmar, and those are just a few examples. I could cite many others. They know what the law says, but they don't bother with it for whatever reasons they may have, based on what the logics of attacks. And so the hard question is, how do you reach them? And I think there are a number of ways. The first one is, as I mentioned, there's been complete impunity. There's never been serious consequences anywhere for these acts. And as long as there's no consequences, the message is very clear that you can do this and get away with it. So the number one thing is to end impunity. No amount of training or affirmations or UN resolutions that everybody signs on to is going to change it. There has to be an end to impunity. And that in turn requires political pressure on prosecutors, pressures on governments. For example, here in the US, there's been pressure on the State Department and Defense Department to share information that could be used to prosecute people perpetrating crimes in Ukraine. And there's been a lot of resistance. So there has to be pressure even at that level. And there has to be attention in Congress. Congress was actually quite active in trying to cut off arms sales to Yemen and to Saudi Arabia because of their crimes in Yemen, but didn't quite succeed because during the Trump years, the legislation got through but was vetoed. And when Biden became president, he said, well, we'll only give defensive weapons, not offensive weapons, to the extent that a distinction can be made, which is highly questionable. And the pressure dissipated. So we need to keep up pressure at every level to force governments and armed groups too that profess adherence to the Geneva Conventions to actually obey them.
Thank you. Another question from the audience. Do you have any information or research to share about the impacts from climate change on healthcare workers? The intersection of climate impacts in war-torn countries.
That is another great question. It's not my expertise, but what I can say is there is no doubt that, from what we know, that climate catastrophes, climate change is spurring conflict. It spurs conflict because land becomes incapable of agricultural production. People are fighting for access to land that can still be used. People are forced to move to cities where there aren't enough jobs or housing and resources so people can survive. Different groups compete for those resources and conflict breaks out. So and that has become clear in a lot of the research on climate. Climate also spurs a huge amount of migration because people can't survive where they're living. And migration itself is connected to conflict. And that we're seeing in Africa, where many people are fleeing countries that in the Sahel and elsewhere where livelihoods have become impossible. And then when they go somewhere else, they're subjected to hostility and conflict can develop. So the connection between climate change and war is quite direct. And there's actually a lot of work being done on it, though not by me.
Yeah. Okay, now the questions are starting to roll in. Let's see here. I've been working with public health colleagues in Ukraine, and I'm amazed at what they have done. But how would any research or teaching here affect the attacks on medical personnel?
Well, the research is important to show the impacts. And the way my experience in the decades I've worked on this is the one way to keep the pressure up is to keep up the knowledge and keep renewing the knowledge. No research is going to, in itself, have an impact on much of anything. But when you do the research, it can become a tool for advocacy or a foundation for advocacy. So you should not think that doing research inevitably has no impact. It's important to build up the evidence on which people who are sympathetic to the cause can rely to put on pressure. And you never know whether that's going to succeed or when it might succeed or when the conditions are right for it to succeed. But it is important to show, and that's why it's important. When you draw attention, and of course, right now we're in a big debate in this country about whether U.S. aid to Ukraine is going to continue. And in that sense, too, the research can show this is why we have to continue. So this research can have indirect political impact for protection of human beings. That's how I see it.
Thank you. The International Criminal Court has indicted Putin for humanitarian violations, attacks on healthcare workers being one. Although Putin himself may never face the court, some of the military officers may. Is this useful, and does this court's action make a difference?
First, I just want to look at the premise for a moment. The premise that Putin will never face trial. A lot of other people were never supposed to face trial. Slobodan Milosevic, who was responsible for the wars in Bosnia and Croatia in the 90s and oversaw many, many war crimes, was immune from any kind of accountability because he was the president of the country. But over time, the politics changed. There were demands when Serbia wanted to join the EU that he be turned over, and he eventually was. So we don't know the future. We don't know how long Putin will be in power, whether there will be a change in government, whether there will be some reason down the road that he is taken into custody. And that's happened with others. Augusto Pinochet, the dictator in Chile in the 1980s, was eventually brought to trial for overseeing torture and disappearances. So we should never think, even if it can't happen today, that accountability can never happen. Second, it's true that right now there are a few people in custody in Ukraine, basically being prosecuted by the state prosecutors. And it's not the same as prosecuting the higher ups. We always want to get to the higher ups, but you have to start somewhere. And hopefully the prosecution of the on the field perpetrators both is useful for holding them to account and setting an example, and can provide a foundation for later prosecutions. The harder question, I think, embedded in what this question was about is, well, does it make a difference? What you look at criminal law in the common sense. Making a crime of murder or armed robbery does not stop murders and armed robbery. But we think, number one, that there's a value to justice. And number two, it may have a deterrent effect. And that can be measured in various ways, even if we can't stop all murders and armed robberies. So we don't have enough data on international prosecutions and their impact because there have been so few. But I think we have to assume that, of course, justice is a value in itself, and that we may determine someday down the road that it has an impact on potential perpetrators. That's where we are right now.
Thank you. Looks like we have time for one or two more questions. Professor Rubenstein, can you discuss how COVID-19 has affected healthcare workers and infrastructure in these conflict areas?
Of course, COVID-19 affected health workers dramatically, even if they were in peaceful societies, because they were attacked, they were vilified, public health officials as well. The same happened in conflict. And actually, when I showed you the map in the beginning, it's an interactive map. And if you go on the website of Insecurity Insight, which prepares the map, and you can see it on the web, and you can see where the COVID-related attacks occurred. And you can see on that map that many of them occurred in conflict settings. We don't know whether they were attacked because they were health facilities or health workers, or because they were specifically associated with COVID. We think it's a mix of both. But I would hazard a guess that that the history of attacks on healthcare and conflict generally helped stimulate more attacks in conflict zones on COVID. I don't have any data to support that now, but that's what I would suspect is the case.
All right, so thank you very much. If there are no more questions from the audience, I think we could be cognizant of time and wrap it up here. Let me just take a look. Okay, I think we've covered all the questions. Yes, we have. All right, Professor Rubenstein, one just popped up. I'm sorry, let's see. Okay, Dr. Peter Orris says, thanks, Len. This is a very informative and a needed approach, especially with the history. All right, so Professor Rubenstein, thank you very much for this talk today and joining us and kicking off our Global Health Lecture Series for this academic year. We really appreciate you taking the time to talk to us. You've given us a lot to think about, and that's it. And so if anybody has additional questions, please feel free to email them to me, and I can send them Professor Rubenstein's way if he's interested in continuing the discussion. And other than that, thanks everybody and have a wonderful day.
Thank you. It's been a privilege to speak with you.
Thank you.